Welcome to Interdisciplinary Case Miles, a podcast where real runner stories meet clinical expertise. We discuss real cases that are anything from weekend warriors all the way to elite athletes, while using our evidence-informed approach.
I'm Dr. Sara Raiser, a running medicine physician focusing on helping runners prevent and recover from running-related injuries while optimizing health and performance.
I'm Kelsey Pontius, a sports dietitian helping runners to fuel smarter, recover better, and help avoid the risk of injury so that they can meet their goals.
And I'm Dr. Mihevc Edwards. I'm a physical therapist and orthopedic specialist, and I've been treating for runners for over 15 years. And what I do is help them get back stronger and better. Today, we are going to break down a really cool case about IT band syndrome. So IT band syndrome is one of the most common running injuries out there. So 50% of running injuries are at the knee, so either patellofemoral or IT band syndrome. And IT band syndrome can be something that is incredibly frustrating for patients because it doesn't always make sense to them as to why it's happening. It is an overtraining issue typically, or an overuse injury. And now the IT band, just so we're all clear, it attaches at the hip and it runs down the outside of the thigh and then right on the outside of the knee. And it actually attaches to the tibia on something called Gerdy's tubercle. So that's below the knee. So it's really important to understand that the foot is really important, the knee is important, and the hip is important when we're talking about the IT band. So this particular case that we're talking about is a female athlete who is about 25 years old. She has struggled with IT band issues for quite some time. The first time she noticed it was actually right after a breakup, which is actually similar to the last case that we did. So I want to point that out in terms of how emotion can impact our physical body. So it was right after a breakup, and she was training a lot more than she typically would because she was trying to manage that issue for herself. And she was doing a lot of hill repeats. So she noticed it after going down a hill. And she finished that day, she was okay, and then the next morning she had a hard time walking. She couldn't extend the leg and she couldn't bend it without pain. She noticed that it was sharp at that knee itself, like the lateral or outside aspect of the knee, and she felt like it just was achy and creaky the entire time. So she originally went to she ended up seeing 4 physical therapists. She saw a physician, and she even talked to a surgeon about having surgery for this knee. When I got her, we did a biomechanical evaluation. So we did functional movement testing. So that is single leg balance, overhead squat with her arms up, because we're looking at thoracic spine as much as we're looking at the feet. I had her do multi-segmental rotation, so where she's rotating from side to side from her shoulders all the way down to her feet, because I want to see how is the tibia moving in relationship to the femur. I have her do single leg squatting. I have her doing single leg bridging, and I'm checking her adduction strength. So those are all some of the things that we'll look at. She had knee valgus, which is where the knee is diving in. She had difficulty controlling femoral internal rotation, so that rotational component of the knee coming in. She did have bilateral overpronation as well. So she kind of had all the things that lead to stress on this area. And she had some hip drop, and that's just with the functional screen. In terms of her run gait analysis, all of those things showed up, but she also is lacking some hip extension, and she had so much hip drop that it was devastating, is I guess the way to put it. It was just so bad that I felt so bad that she had that much hip drop and her knee was going in quite a bit. So that's kind of the clinical picture. And I'll talk about interventions in a little bit, but first I want to draw Sara in so that she can talk about, like, what would she want to look at, what would she want to know about this case?
So in this case where someone is presenting, they've already seen lots of providers and been through courses of PT. A couple things we may want to work on. Number one, we may want to rule out, is there something else underlying all of this? So is there a hip joint condition like hip impingement or a labral tear? Is there something going on in the knee joint? Did all of this start when they had an injury and started compensating? So looking at all of these different injury patterns, even considering things like the pelvic floor and the abdomen, because the low back can change its angle, your pelvis can change its angle when you have abdominal pain or constipation, or you've had an abdominal surgery, you've had a baby. So a number of different things in medical history that could potentially give some more insight into why this may have started in the first place and anything we may need to look into a little further. Usually, from my perspective, my main role is being the cheerleader here. So saying, I know I'm sending you back to some physical therapy, but this is what's going to be different. This is what you need to look for that should be different, and all the different components that should be included. And also, this can take a lot of time because changing biomechanics does not happen overnight. This is the muscle memory piece and that neuromuscular control, and the body figuring out what needs to happen, as well as the brain figuring out how that connection happens as well. So a lot of this, I did this just today, one of my last patients today, of how important it is to really hone those biomechanics. Otherwise, things are not going to get better. And there's usually a delay. You improve your biomechanics and you're like, hey, things look great. Why do I still have pain? Well, it takes a while of operating without those abnormal biomechanics before pain starts to go away as well. Sometimes I am potentially also doing things like shockwave therapy or some selective types of injections to help with pain, but usually these are adjuncts or trying to stimulate some level of healing, like some other regenerative medicine techniques. So I may do these things. Sometimes it's even just trying to get someone's head back in the game. So if we can get just some quick pain relief, sure, steroid injection may wear off at some points. This is maybe a hip or knee injection, for example. If we can make some progress while we're having pain relief, maybe we can make some changes. And one thing that's interesting too, I find that hip joints that hurt are much more likely to subconsciously change biomechanics. And so sometimes actually trying to calm down pain from the hip joint perspective you can make some really big gains with that. Even if someone's like, it doesn't really hurt that much. I found that people have more success with the PT. So those would be my main roles. And then, of course, we might delve into the REDS piece. So is there a component of low energy availability, fatigue, stressors, sleep? And that would also be my potential role, is like, how do we optimize all these things so you have the wherewithal to go to PT and make the time for it, do your exercise at home, and then be able to manage this path that might take some time.
Awesome. And Kelsey, if you saw a patient, I know this is a lot of biomechanics, but what would you want to do to help support this patient from a nutritional standpoint? And I will say that this patient does not have any red symptoms. So they are really good, because that's something that we do screen out. They're really good in terms of their fueling around their exercise, as well as full day.
Awesome. Yeah. So once that's ruled out, and just saying that, REDS can create more inflammation in the body. So once that was ruled out, I'd be really interested in their hydration. I think about sometimes when hydration is an issue, then a lot of tendons, ligaments, all of those types of structures, connective tissue in general, won't glide as well. If we think about beef jerky, and the fraying of beef jerky is a lot of times the analogy that I make. So hydration's really important. I would be interested, what's the nutrient density like? So we know we're eating enough. That's awesome. But what is the nutritional quality like in the diet? Are we eating foods that help support the body's own collagen production? This person is young enough to where their body should be able to produce their plenty of their own collagen. So foods that help promote collagen production are foods that are high in vitamin C, copper, zinc, those types of foods. And so just making sure of that, making sure that because we just went through a breakup, we aren't, completely ignoring nutritional quality. And I think that those would be the biggest pieces. I think that while they're dealing with these symptoms, I would encourage a collagen supplement prior to doing their PT. Just, one more thing to help support their bodies. And then whether they wanted to maintain it or not, I would give them the pros and cons of that.
Well,
And
I just learned a lot. That was great.
I
Yeah.
was just thinking too of one more thing that I was going to mention, and I bet Kate is going to have some things to say about this too, is that I think it's also really important to touch on the insight piece. So in this scenario, if someone's going through a breakup and running might be a great stress reliever, on days that they feel like they have lots of energy and they want to run a lot. Well, why do they feel like they have lots of energy? Is this cortisol because they're really stressed out? And actually, what they might need is some meditation to calm things down and really develop that insight and how they feel. I think I developed this insight a little bit from using the data points, right? So HRV and HR. I don't use them all the time. However, I happen to have a couple numbers, and sometimes when I need to check in, I'll look and see, is my heart rate really up and my HRV is down? And it kind of corroborates like when I'm thinking, am I feeling lazy or am I actually like really exhausted? I think sometimes that can be really valuable because if you're in a stress state, those numbers are not going to look so good. So sometimes using some of your resources like that strategically, not all the time, I think can be valuable too. So really helping folks kind of delve into that insightful piece because it can feel really good to run off that cortisol, but it may not be what your body needs at that moment.
Sarah, the kids call that a rage run, I think is what you're referring to.
A rage run. I mean, I don't know
I'm
if you
getting
have to be
old.
I don't know if you have to be a kid to do a rage run though.
But when you're hurt, you can't
Yeah.
rage run. I
Yeah,
know from
it's
experience.
me too. All right. So with this, I actually love both of the perspectives you just brought to that because it's not a lot of what we hear. When patients come in, they don't really get that. So thank you. I learned from both of you in that case. Some of the things that I would like to mention in terms of this case is the reason the injury probably occurred where there were a couple things, right? The increased emotional load from the breakup, but also a spike in training and downhill running and not being able to control how their leg is landing from an eccentric perspective and also that dynamic control of the knee. So the things that we would want to work on in PT were we wouldn't really do soft tissue of the IT band itself. This is something actually Sara and I were talking about before we were recording. I would probably do a lot of treatment in the vastus lateralis, which is the outside part of the quad, and also the hamstring, as well as the TFL, which is the top of the IT band. So I would work through all of those muscular structures in terms of soft tissue or maybe some dry needling. I would make sure that they had good hip extension. So I would do some manual therapy to make sure they have good hip extension. I would also check out their pelvis and their lumbar spine to make sure everything was moving appropriately there so that they can hip extend appropriately and flex their hip appropriately. I would go down to their foot and ankle and I would make sure that they can dorsiflex. So, bring their foot up and down appropriately and that they had good control from like a side to side, which is their subtalar joint. Because when their foot lands, how their foot lands impacts what happens at the knee from a rotational component. So that would be what I would do from like a manual therapy perspective is I wouldn't just treat the IT band. It would be all the way up and down and probably even in the thoracic spine. For this particular person, they also had a lot of tightness in the pec muscles and they were super stressed because of the emotional component. So I wanted to do some breathing, like you mentioned, some meditation or some breathing. So I paired it with a pec stretch on the foam roller so that they had to breathe, spend a couple minutes stretching out their arms so that could help with their arm swing, but then also working on that down regulation of the nervous system and getting them to breathe. And that helps with core stability too. So just talking to the patient about how those are all interconnected. So I did that. We worked on foot and ankle strength. So super boring exercises when it comes to the foot. Lots of single leg strength where they're barefoot and controlling the arch of their foot, being able to push through that big toe so that we can control that rotation from a pronation, supination standpoint. something that can happen with IT band syndrome is that you can either be an overpronator or you can be an underpronator. So you might be in a lot of supination. So your foot is kind of leaning on the outside, or what we call the lateral column. So you might be getting a lot of stress up the side because you're not able to dissipate the force enough. So there are a lot of different reasons why this could happen, but these are things that need to be addressed from a physical therapy and a biomechanical standpoint. And I'm looking to make sure there's anything else. Oh yeah, and obviously like rotational control from like a core standpoint. So probably some side planks with some reaching, or even some rows, or some on your hands and your knees with maybe some rows or dead bugs. Things like that would all be within the program. So we would do a combination of manual therapy, education, re-education with exercise, and then we would go and do some gait retraining. But I wouldn't do the gait retraining until I knew that they could move through the range of the motion that they needed to do. So if they don't have really good hip extension, it doesn't make sense for me to try and change what they're doing. Or if they can't move their arm appropriately because they're so tight in their chest, then I'm not going to change their arm swing. So I want to make sure that I clear all that from a manual therapy standpoint and a functional standpoint before I make the changes in terms of the gait.
At what point of the program would you, I've never heard the terminology gait retraining. So at what point of the program would you do that?
Yeah. So when you do a gait analysis,
Mhm.
what you're looking to find what's happening, like find out what's happening, right? And once you find that out, so you can modify. So gait retraining is when you're modifying somebody's running gait. And so this is research informed. It's not evidence based. So those are two different things. So that means we know that we're using research concepts to help change the way force is being absorbed and people are moving, but we don't have the strongest level of evidence. But we have seen clinically this helps too. So when gait retraining is teaching them how to properly arm swing, or maybe modifying their running cadence, or maybe getting them to run with a wider base of support, which is one that I might do for IT band, because if you have a lot of crossover gait, you're really loading that lateral column. So that could look like a lot of different things. There was a recent paper out there that outlined what a good gait retraining system would look like, and it was like 2 to 3 times a week for 6 weeks. You would have this person do this one thing that you're teaching them to do for a certain number of minutes. The way that we do it in our clinic is that we'll have people go out for a run, and we'll have them focus on that one thing. I'm going to use arm swing just because for simplicity right now. We'll have them work on their arm swing for the first few minutes of their run. And we've explained how we've given them running drills, how to do it correctly. We've made sure, biomechanically they can handle it. And from a manual therapy standpoint, they can handle it. Then we'll say, forget about it for part of your run so you can enjoy it. Do it again in the middle, and then do it again at the end. And we'll have them repeat that throughout their runs. And we can use some of their data from Strava or from their Garmin's or whatever it is, whatever they're using, to look and see if they're able to do what we want them to do. So that's how we'll do gait retraining in our clinic, is we'll do it. And then we pull them back in after a few visits, have them hop on the treadmill or outside, depending on how we've done it, and have them repeat what we've taught them to see if it's actually sticking. And we'll do that a few times throughout our care.
One more thing I was going to mention too, in any of these biomechanical cases, this is something especially that I will use when I don't necessarily have a ton of time and I can't put someone on a treadmill necessarily during my session, which I know you don't always have time during your session either, Kate. But looking at feet. So I was looking at someone's feet today and they're like, I'm so sorry for my calluses. And I'm like, no, this gives me great information.
Yeah,
Not that I
does.
want you to have them, but I can really get an understanding for what's happening with the foot. Because when I did a lot of her, dynamic evaluation that I could do in the office without a treadmill, things look pretty good. So I'm like, what in the world is happening? Because your foot grounding looks good and your first race stability looks good. And then, I look at her calluses and like, oh, now I understand what's happening when you're dynamic and you're actually running. And so I was kind of going through things with her. I think the other thing too is shoes. So we were talking
Yes.
a little bit about lateral loading as being a possibility. So being able to take a look at how shoe wear is happening. And I love the fact too that you mentioned with your gait retraining that you don't have someone do do that 100% of the time. And I always preface when I have someone get on the treadmill, I'm looking their gait. I'm like, look, number one, we're looking for gestalt. What's happening here? What are the big picture things? How can we guide physical therapy? And then maybe I might give you a thing or two in terms of tips for when you're running, which might be a simple thing like arm swing, or I call it line running. So trying not to cross over essentially. But otherwise, yeah, I just want people to run when they run. We'll work on the stuff on the back end, but we can end up causing more problems if we really try to change things drastically.
Yeah, and I always give them one thing to work on, and that one thing, because if you change more than one thing at a time, then it changes everything. And you don't know what's helped, you don't know what's made it worse. So you have to really just give them that kind of one thing. And there's so many different ways you can go about that. And I love that you brought up shoes, because shoes are what everyone thinks that it's the shoes problem. And most of the time it's nothing to do with the shoe. Every once in a while, though, there are things that you need to know. So in terms of running shoes, if you've got a lateral column issue, so that could be IT band, that could be shin splints, that could be a lot of lateral ankle sprain or outside of the ankle sprain. There's so many different things that can happen out there. But it might be a lot of people put their orthotics inside the shoe on top of the like liner of the shoe instead of taking it out. And that can create more of that kind of supination or pushing your foot out. The other thing that often happens is that they'll get a shoe that has a lot more support than they need, and that can push them out too. So it is important to get a shoe that's really comfortable, most important thing, but you don't want to layer orthotics on top of the liners, on top of something that's already supporting you too much, because that can really throw you out to the outside of your foot. And I look at the shoes in terms of where the wear patterns are, but also like, if you can see where their big toe is pushing up, you know that they're not really pushing through their big toe when they're running. Or if you notice that there's a lot of dirt on the inside part of the ankle, their glutes probably aren't doing their job. They're probably kicking themselves. So they're probably not firing the outside of the hip, or they're crossing over. So there are a lot of different cues. Like you can decode so many things. I'm getting so nerdy. I'm sorry, I'm almost done. You could get so nerdy when it comes to running shoes and like looking at them and figuring out what it means in their gait.
I know, I just always have so many personal follow-up questions. I'm like, so you're telling me my right shin is always dirty for a reason?
Oh yeah, for sure. That's something that I look at when people run. And that's something I ask them. Like, do you have dirt on your shin? Do you have dirt on your calf? Do you have like, some people's medial malleoli, or like, what is that in regular terms? Like inside of the ankle? Is that what we're
Inner
gonna call it?
knob.
Inner knob. Okay. So that sometimes bleeds. And then you really know, like, oh my God. Or even like the chafing in between your thighs. That is another
Yeah.
sign that you're like hip dropping and that your glutes not firing. So we could go on for days about this, but this is these are like the little signals and the things that you're looking for and asking patients. So
So cool.
cool. All right. Well, I think that is it. Let's go back and kind of loop back around here for a second. So to close this up, Kelsey, what are just a couple things or one thing you really want people to take home from this?
Yeah, I think with all of my interventions with this, I was thinking about the hydration, the collagen, the foods that promote collagen production. I didn't mention this, but I thought about it after the fact. Foods that help manage inflammation, all of those things are kind of like when Sara was talking about pain needing to go away after the biomechanics are fixed. All of these things are going to take a few weeks, 4, 5, 6 weeks to make a difference. And so I think that kind of understanding the consistency piece of those are going to be really, really critical, and not expecting a quick fix, but trying to look for improvement and not letting that you still feel things say, okay, the nutrition isn't working.
Great. And Sara, what about you?
So I think the insights, which I think there are insights on so many different levels. So understanding what your stressors are, understanding when you feel good or bad, why that's happening, and how you should respond to keep your body safe. And then definitely setting expectations for how long these types of biomechanical things can take to get better, but that we can get there. It's going to take some time and some dedication to what you're doing.
Great. And then my last thing would be kind of piggybacking on both of the things that you guys said, is that muscles, it's 4 to 6 weeks before you can really retrain a muscle from a neuromuscular standpoint, but it takes 8 to 10 or 12 weeks for a muscle to actually get stronger. And so that is what we're thinking about when we're thinking about biomechanics and strength. So you will start to see benefits within the first week or first few weeks, but it does take a lot longer than anybody really wants to wait. So be patient when it comes to these and these injuries. And there are ways to modify your gait. And there are things that you can do with running shoes or orthotics. And again, I'm not like a huge fan of orthotics all the time. I think they're great for offloading tissues when you need them, but not rely on them forever. But those things can be useful in this time if you really still need to run and exercise. And just finding another outlet is also really important. Finding something in addition to running that can help you when you're in a stressful period of time. So thank you very much, you guys. This was super fun. I really got to nerd out on this case. That's great. But
I have so many ideas for our next cases now.
Okay,
We've got
good.
sports identity. We've got reading feet and shoes.
Oh, that's awesome.
We need another provider. We need a therapist on here.
We do need a therapist at some point. And I don't know if it's for us or for everybody.
I was thinking it. I just didn't say it.
That's okay. So thank you everybody for listening. We wouldn't be here if we didn't have people following us and listening. So if you love this podcast, please send it along to your friends, send it along to other providers, send it to your provider maybe. But the more you pass this along, the more you share it, the more you follow it. If you give us a rating, that can be very helpful to get this out in the world. And we would be so very appreciative of it. If you have a case that you want us to talk about, go ahead and email us at runcasemiles@gmail.com and we will take a look at it and we will go through it one of these days on the podcast. So thanks very much and have a great day.